NCCT brain was done, which was normal. And USG abdomen to rule out any occult abscess or maybe in the TB abdominal, this was normal. And there is echo was done to rule out just occult and infective endocarditis. Other serological marker also was like Bedal, Varicella, and Leptospira, all was negative. Before coming to here, she was already received good antibiotic IV for the 10 days, and she was also taken some rheumatological opinion, for they have some diagnosed some unknown rheumatological disorder. So she was put on the naproxen, but because of deterioration symptom, she was came to an Artemis emergency, and on examination there was raised ICV features because of tachycardia, along with there is hypertension, and fundus examination also showing there is a mild papilloedema. So immediately the basic treatment for the RAGE ICP was started, and other investigation was which was not done previously, like MRI brain with contrast, CSF study, and EEG was planned. So this is the MRI image, flare and T1 image with T1 contrast. There is a very subtle finding in the MRI. There was not obvious finding. There is slight bulky posterior medial thalami, and there is subtle gyral enhancement in the temporal regions. So it was reported as a query leptomeningeal enhancement. So we have done the CSF study, and this was the EEG also done in the same day. So you can see very clearly. There is an intermittent slow wave and sometime intermittent generalized slow wave, along with there is a few mixed sharp wave was there. So there was definitive cerebral dysfunction. And we did an investigation which was like a routine investigation. Again there was a mild raise, TLC and CRP was high, ESR was high, other parameter absolutely normal. And CSF was showing significant pleocytosis, 95% cells which were predominantly lymphocyte, mild raise proteins and sugar was normal, and lactate was normal. So of course this was patient belonged to some good family background, so we immediately sent for the other investigations like CSF autoimmune panel and viral panel complete, and gene expert was done which came same day negative. And because of these symptoms we thought of autoimmune, so we started immediately the management like IV meropenem, Vanco and acyclovir along with RAGE ICP management, along with IV methylprednisolone on day 1. On day 2, child was having deterioration in the form of sensorium was going to deteriorate in spite of steroid. So there was no much time, so we have to initiate second line treatment, first line treatment IVIG. So this was along with steroid, IVIG also started on day 2, and after IVIG almost 4 or 5 days later, child was having significant improvement in the form of headache was disappear, sensorium was improved, and child able to walk, but there is a little ataxic gait while walking, it was not completely normal. Viral marker came early, so which were negative, but autoimmune panel always takes some time, so it was awaited, but came positive on the day of discharge. This was MOG antibody positive. So this is the one of the rare presentation of MOG encephalitis is presenting as a pyrexia of unknown origin. There are few case reports from India, like Dr. Rodani has reported many cases. The MOG is presenting as a pyrexia of unknown origin. She is presently doing well, presently on the low dose of steroid along with azathioprine, steroid sparing agent, perfectly all right. I have repeated the MOG antibody after 3 months, which is weekly positive, but symptom wise is normal, EEG also normal, so we will continue the low dose steroid along with azathioprine. This is the second case. This is the very short history, 1-year-old female child with normal birth and development history, and child have only fever history since last 2 days, and excessive irritability, continuous irritable child, not able to settle at all even in spite of small dose of midazolam. So there is very extremely irritable behavior. On examination, child having altered behavior and mental status. The behavior was extremely irritable. On there is subtle finding of having abnormal dyskinesia and reflexes are brisk, but there was no clear-cut history of seizures. Of course, very brief history, or just 2-day history, and with extreme irritable behavior, or the first working diagnosis was meningoencephalitis, query meningitis. So we have planned investigation, that MRI brain with EEG and CSF study. MRI was done early stage, so it was normal. There is no obvious abnormality was noted during MRI. Yes, but there is a subtle finding on EEG on the central and temporal region. There is subtle delta brushes, along with there is some slowing also there. So this is the early clue just we having in this cases, very short history, otherwise we not thinking about any kind of autoimmune disorder. So on the, you can see central region or temporal region, there is delta brushes. So of course, CSF was done. CSF was showing there is mild pilocytis, only just 10 cells which were lymphocyte predominant, rest is normal. And CSF viral BioFire was negative. Autoimmune valve panel was sent, which take time. And there was a mild papilloedema, and other investigation was normal. So initial treatment was given, IV antibiotic along with acyclovir and RAIPUR management. And to calm down, we were given the clonazepam higher dose and also given antiepileptic just a prophylactic point of view. In view of suspicion autoimmune encephalitis, child was not improving IV steroids, so we added on day 2 IVIG. And after IVIG completion, child was having improvement in the form of reduced irritability, child was able to manage, and there is a relief in the movement also after adding dyskinesia. We have given just Revocon for the same. And this is the very small child I have seen, first only 1-year-old child having NMD receptor encephalopathy, first case. I am having 2-3 cases that are mostly over the 5-year age. So she's on follow-up, we have ruled out any teratoma by USG. On follow-up, she is better, absolutely fine, only low-dose steroid and azathioprine. And we have planned for the repeat CSF, the child. This is the also one brief case. 2-year-old child with normal birth and development history, initially presented with pediatrician with simple febrile seizure and transient encephalopathy. So child was treated in ER, given some dose of steroid, and child was settled in the PICU. So child was did not investigated for the encephalopathy point of view, and child was not done any EEG and MRI. So actually came to me after almost 2 weeks later with complaint of again lethargy, decreased activity, there is significant encephalopathy, and there was no seizures. We have done MRI, which was showing very classical finding of ADM like changes. So it was missed in the initial admission, maybe just transient encephalopathy given maybe single dose of steroid, but after 1 week or 2 week deterioration again happened, so came to again. So we given IVIG and steroid, and serum MOG was done, which was came positive. Presently she is on follow-up, completely fine, and even MOG antibody after 3 months we have done, which was negative. So this is the report, initial report and the follow-up reports have been negative. So briefly slide about the what is the MOGAD. MOGAD is the variable spectrum presentation of MOG antibody presentation. It is a rare type of disorder. In pediatric age group, most common presentation is the ADM. In adult is most common presentation optic neuritis. There is other presentation having like transverse myelitis, cortical encephalitis, and there is sometimes multiphasic presentation more common in adult as compared to pediatric age group. ADM is the presentation mostly in the smaller age group. It is monophasic, mainly present single episode. It having a symptom of systemic like headache, nausea, vomiting, malaise, altered mental status, and there is more specific symptom also depend upon the area of involvement. So I am not going very detail about the treatment, mostly all we know, the protocol to how to treat any autoimmune encephalitis almost is the same for the MOG or an NMDA, similar. So if any child having symptom like MOG encephalitis, clinical presentation, then of course first line treatment is IV corticosteroid, pulse dose steroid, which is 20 to 30 milligram per kg, initially for 3 to 5 days. If a good response, we will continue the same. If it's partial response, then add on IVIG to be given. If there is partial response on even a spite of IVIG, then may require plasma exchange. In case of relapse, first line after IVIG and steroid, if case of relapse happen, so first you treat the relapse, acute treatment, similar with the steroid and IVIG. Then you may require add-on like oral corticosteroid plus azathioprine or injectables. In injectable, either you may choose rituximab or maybe IVIG monthly. If it happen initial recurrence on the oral, then you require IV, and later on if you having IV, then you have to second IV. If you having on that, this rarely you will require all these three modality of treatment. But mostly MOG respond on the first line treatment. They don't require so much in pediatric age group intensive treatment. This slide just showing about the doses of this regimen. And last slide just for the international recommendation for NMD receptor positive antibody encephalitis. This is also almost similar. I'm not going very much detail as time does not permit. So I will just highlight a few key points from my slides. In pediatric age group, if his child is having meningoencephalitis presentation, carefully to look for the autoimmune disorder. MOGAD is the most common CNS disorder in the children. If febrile seizure with having encephalopathy, then we have to look for other cause like ADM or MOGAD also. A child with having PUO presentation with soft neurological sign may require other autoimmune disorder to be looked for same. And clinical suspicion autoimmune disorders should be not delay for the report. If you are having any suspicion, treat immediately, don't wait for the report, because clinical outcome is very excellent. Thank you, sir.
So thank you very much. There are a couple of questions here. Do you get GABA A receptor antibody in all patients who suspected of ADEM or other encephalitis?
Sir,
do you have facilities
yes,
to get GABA A?
Usually we send the autoimmune CNS panel that include GABA A receptor antibody.
No, that includes a GABA B.
GABA B also.
That includes a GABA B, and GABA A is not there. So Adam has got a close differential diagnosis with GABA A encephalitis,
okay,
which has got that kind of a lesion, confluent lesion, and they present with a recurrent seizure. So I think in a panel, autoimmune panel, GABA A is not there, GABA B is there.
I will check the survey, definitely.
Yeah. And how common is this thalamus involvement in, like your first patient, posteromedial?
Sir, most of cases having thalamic involvement in MOG cases, we having whatever we cases having MOG positive, they having some asymmetrical, yeah, maybe symmetrical thalamic involvement is there.
So if you take a classical classification of this group of a disorder, in which group you classify it, as a brainstem involvement or diencephalic involvement, or for that matter, any of
involvement more?
Good one, Dr. Jeet. The other question was regarding how quick you are to start on immunomodulator. Like, see, like of your pyroxia of unknown origin, because you got only MOG positivity, otherwise so many other thing was also there. So how brisk you are, or how quick you decide, okay, you have to go for the immunomodulator, because in kids, it's really...
once there is a clinical history having suspicion of autoimmune.
And for how long?
Even pediatric age group, even short history, after even short history also having, if is after ruling out MRI, after ruling is a CSF studies, like infective viral as you rule out.
Okay. The question is, for how long you want to give? For how long time? How much time?
The duration of treatment.
Yes, yes, yes.
Most of these MOGAD cases, they require at least 2 years of treatment. For NMDA, it will require maybe prolonged over a duration, depend upon the symptom. And if the symptom is not resolving, then monthly IVIG, depend upon the age, yeah, maybe the rituximab can be second line drug can be added. So the treatment for the NMDA, usually pediatric cases, more than 2 to 3 years is required.
So it appear like it's day 1, day 2, day 3. By day 3, child is on both IVIG plus a steroid without waiting for reports to be a positive. So
mostly, sir, after steroid, day 2 or day 3.
So you start with the broad spectrum antibodies, antibiotics, that too meropenem and that kind of a thing, combined with the vancomycin, and then you quickly gone for this two things, steroid and IVG together. So these are the current recommendations.
Depend upon the one of the things is the patient affordability also. Mostly we treat day 3. If is poor response, then we add usually IVIG, day 3, most of cases.
Chalo,
After-
thank you. Thank you, Ajit. Thank you very much.
Thank you, sir.
Wonderful. So may I invite Dr. Rashmi to present a patient with a hemiplegic migraine. So she is planning to publish these cases. These are genetically proved cases. So have a careful listening on this her cases.
ये था ना कौन सा ये इसको निकाल दे तो काम नहीं करेगा
Good afternoon, everyone. Thank you, Dr. Sanjay Sharma sir and the organizing committee for providing me this opportunity. Today, I'm going to present on this very short case, single case of this novel ATP1A2 gene mutation in familial hemiplegic migraine with epilepsy. My case is a 10-year-old girl with history of right-sided weakness and aphasia accompanied by migraine-type headache, including throbbing pain on the left side with vomiting and blurred vision. Her migraine symptoms improved gradually except the motor weakness, and the weakness lasted for about 7 days, and after the attack there was no residual neurological deficit was identified. And she had previously suffered the similar clinical episode 1 year back and with left-sided weakness. And she had afebrile seizures, which was started at the age of 3 years, and she was on anti-epileptic drugs up to 8 years of age, and now she is not on any anti-epileptic drugs. She was evaluated outside for autoimmune encephalitis, and NMDA and all receptors were negative. Her mother have migraine, and she had also had a single episode of transient weakness of right upper and lower limb for about 24 hours, few months back. In examination, general examination including CNS were all normal, all blood routines were normal, MRI brain and EEG was normal after the attack. So based on the clinical symptoms and family history, hemiplegic migraine was suspected and whole exome sequencing was done, and this revealed ATP1A2 gene mutation. So this case was diagnosed with hemiplegic migraine type 2, and she was put on 5 mg flunarizine as a prophylaxis, once daily dosing. And after 4 months of follow-up right now, she had no further episodes of headache or any neurological weakness. As per ICHD-3 classification for hemiplegic migraines, they classify hemiplegic migraine into sporadic or familial forms, and familial hemiplegic migraine is divided into 3 types. Type 1 with mutation in CAC, NA and 1A gene, and is the most common type, accounting for 50% of the cases. And it is this type 1 is usually associated with cerebellar degeneration. Mutation in ATP1A2 gene causes familial hemiplegic migraine type 2, and mutation in SCN1A gene causes familial hemiplegic migraine type 3. So these are diagnosed by aura of reversible motor weakness and involvement of at least one first or second degree relatives. So as per ICHD-3 classification, at least 2 attacks and one or more of the aura symptoms like reversible visual, retinal, sensory, brainstem, motor, speech or language, and 3 of those following characteristics. One aura symptom spread gradually over 5 minutes, 2 or more symptoms in succession, at least 1 unilateral symptom, 1 positive aura symptom, and lasting for 5 to 60 minutes, and aura which is accompanied by or followed by headache within 60 minutes. Coming to the pathophysiology, the alpha-2 subunit of sodium potassium ATPase is expressed mainly in the astrocytes and the pyramidal cells in the hippocampus, and this pump exchange intracellular sodium for extracellular potassium. So loss of this pump results in a raised extracellular potassium as well as glutamate in the synaptic cleft, which facilitates the also cortical spreading depression. In the we can see in the synaptic cleft there is accumulation of potassium and glutamate, which facilitates cortical spreading depression and intracellular accumulation of sodium. Also the sodium calcium exchanger is also hampered, and this results in increased intracellular calcium, which further facilitates cortical spreading depression due to hyperexcitability. Cortical spreading depression, the mechanism of aura is a cortical spreading depolarization initially described by Ley in 1940s as cortical spreading depression. So it is a bioelectrical phenomena, initial phase of cortical hyperemia followed by cortical oligemia. So aura manifests in this order, yesterday also explained by Dr. Sumit sir, in the order of visual first, then sensory, motor, the speech and the brainstem symptoms. A new idea is that a cortical spreading depolarization involves the cerebral cortex and or the thalamic nucleus has been proposed, and this affects the different cortical functional networks through a thalamo-cortico-thalamic connections, and this explains the complex sensory aura and even the bilateral auras. So how this sodium potassium ATPase dysfunction is linked to migraine. So that is dysfunction of this pump leads to increased extracellular potassium, which decreases the activation threshold for migraine. Also there is a release of ATP, glutamate, potassium, CGRP and nitric oxide within the synaptic cleft, and this activates the meningeal nociceptors resulting in headache. The throbbing character, it is due to the sensitization of the trigeminal-vascular nociceptors. ATP1A2 and seizure correlation, they are not a separate physiological event in the brain, and they persist along the dynamical continuum of membrane of neurons, and experiments have revealed that extracellular potassium concentration causing seizure was lower as compared to cortical spreading depression. So epileptic seizures, they can be converted into spreading depression when the glial potassium buffer capacity decreases. So this explains the prevalence of epilepsy and is higher in migraine, and why it is more common with ATP1A2 mutations. So the ATP1A2 and transient motor impairment. So loss of this function of sodium potassium ATPase lead to increase in serine and glycine in the brain, and the diet free of this serine and glycine, they can rescue the transient motor impairment in hemiplegic patients. D-serine basically is a synaptic NMDA receptor co-agonist, which leads to cortical overexcitation via glutaminergic transmission. Treatment of the acute episodes with NSAIDs and antiemetics. For prophylactic, initial therapy with verapamil, flunarizine or acetazolamide is recommended. And other medicines we can give is ketamine, lamotrigine and naloxone. Verapamil can be used both as a prophylactic and abortive agent in hemiplegic migraine. Triptans and argitamines are not used because of risk of cerebral vasoconstriction. And there is no evidence for the use of DTANs and GPANs in this case, but they are not cerebral vasoconstrictors, but they are, yet there is no evidence for that. Other pathologies associated with ATP1A2 mutations are alternating hemiplegia of childhood. Differentially, there is no developmental delay in this child or any mental retardation or any movement disorder, which are usually associated with alternating hemiplegia of childhood. Other benign familial infantile convulsions, generalized epilepsy with febrile seizure plus, and RCVS, basilar migraine. So according to this mutations and various phenotypic characters have been mentioned. So to conclude, epilepsy appeared first in this patient, and then the hemiplegic migraine was added to the phenotype in the patient with ATP1A2 variants. This mutation has the highest number of reported patients with both epilepsy and hemiplegic migraine. Drug-resistant forms of epilepsy are rarely reported with all the mutations and familial hemiplegic migraine. So this information is important for counseling your patients. Thank you.
Rashmi, fantastic. I think there are only two clues that you got the history of a migraine in a mother, and second thing, a family history that the mother has got a episode of a hemiplegia, transient hemiplegia.
Yes.
What's missing is a semiology of a seizure, which we are looking forward, whether it was a focal motor seizure arising from a same motor strip, and we are looking for a details of a phenomenology of a headache which you have not described. What kind of a headache?
Yes,
So
sir.
both the things on a clinical ground is, I think it's missing. The semiology of a seizure should be a detailed one,
Yes.
and the phenomenology of a headache, what's the sequence, what's the duration, whether it started with a visual or suddenly she gets a what.
Yes, sir. Okay. Thank you, sir.
Okay, then we move on to Chhatrapal. Huh? Pehle Chhatrapal. Let's start with Chhatrapal, then followed by Dr. Bhoi. Dr. Bhoi, you are not visible. Come forward. हाँ वो तो तेरा तो फाइनल प्रेजेंटेशन है. So this is a fantastic work which Chhatrapal is doing, looking after these embolic patients, and I have also contributed a case, and we have already written an article, but still article is not approved for a publication.
Good afternoon all, and thanks to Sharma sir and the organizing committee for giving me this opportunity. In next 10 minutes I will be speaking about a very rare complication of a common disease in our region, that is sickle cell disease. Fat embolism syndrome is a very rare complication, but we should know about it because it has a very high mortality, and timely treatment can reduce the mortality. Coming to fat embolism syndrome, it is a clinical phenomenon that is characterized by dissemination of fat emboli within the systemic circulation. So these emboli disrupt the microcirculation and cause also systemic inflammatory response syndrome. And this affects respiratory system, followed by CNS, skin, and other organ systems. So coming to causes of fat embolism syndrome, mostly it is reported in cases of trauma, especially fractures of long bones. Non-traumatic causes are very rare, and they include fatty liver, acute or chronic pancreatitis, corticosteroid treatment, and hemoglobinopathies including sickle cell disease, thalassemia. So the clinical presentation, it consists of a classic triad of respiratory distress, neurological signs, and a petechial rash. Respiratory symptoms have insidious onset after trauma or an inciting agent. It usually appears after 12 to 24 hours, and they consist of dyspnea, tachypnea, and hypoxemia. And in fat embolism syndrome, about half all the patient develop respiratory failure and may need ventilatory support. Neurological symptoms are present in 80% of patients, and they occur usually after pulmonary symptoms. The clinical features are confusion and agitation that may progress to focal deficits like hemiplegia and aphasia, and further coma may occur, and seizures are also reported. So skin changes, a rash is seen in 20 to 50% of patients. This petechial rash has a characteristic distribution in the upper parts of the dependent patient, like in the head, neck, and axillary region. And as the fat droplets are lighter than the water molecules, they are usually seen in the non-dependent regions of the body. So this is the axillary petechiae and subconjunctival hemorrhage. So these are criteria, GERD criteria and Schoenfeld criteria, but in the context, they are useful in the context of trauma. In sickle cell disease, they are not of much use. So pathogenesis, there are two theories for this fat embolism clinical manifestations. One is mechanical theory and the other is biochemical theory. So the mechanical theory just implies that fat droplets or fat emboli, they block the microcirculation of the in the capillaries of the pulmonary vasculature, and when they find a shunt in the from right to left in the form of pulmonary AV fistula or patent foramen ovale, they cross the left side and then they again produce microcirculatory block and cause symptoms. While the biochemical theory proposes that fat embolism syndrome is a pro-inflammatory state because the hydrolysis of fat droplets produces free fatty acids which cause inflammation of the endothelial cells, and again there are arachidonic acid metabolites are released during this process which are pro-inflammatory cytokines. So it is seen as a inflammatory response syndrome. And in practice, it is the combination of both theories. Lab studies show anemia, thrombocytopenia, and elevated inflammatory markers. Chest radiographs may show bilateral diffuse fluffy infiltrates. HRCT is characteristic in fat embolism syndrome, and it shows dilated, thickened interlobular septa with ground glass opacities. Brain CT is usually normal. MRI is more sensitive for detection of fat embolism syndrome, and it demonstrates a star field pattern in DWI images that is punctate and discrete bilateral small non-confluent foci over the subcortical and deep white matter region. There is also SWI hypointensities which is diffusely scattered in the white matter of bilateral cerebral hemispheres and cerebellar hemispheres known as walnut kernel pattern. Coming to sickle cell disease and its relation with fat embolism, we know that sickle cell disease results from the mutation at 6th position of beta globin chain, and it is characterized by intermittent vaso-occlusive crisis and chronic hemolytic anemia. And it is its prevalence is very high in Chhattisgarh, maybe up to 10%. These vaso-occlusive crises can lead to avascular necrosis of bones involving the hip joint and vertebral column. Fat embolism syndrome occurs in sickle cell disease due to this extensive bone marrow necrosis, and it's a devastating complication which is associated with great morbidity and mortality. And it has a clear predilection for non-homozygous forms like HbSC disease and HbS beta plus thalassemia. And so milder forms of this sickle cell disease, it carries the highest risk for development of fat embolism. And also has been an association with human parvovirus B19 infection in sickle patients who develop the fat embolism syndrome. So this is the pie chart which shows that HbSC heterozygous patients form the 50% of fat embolism, and HbS beta plus thalassemia, then other unknown variants followed by the homozygous pattern. This is the prevalence of fat embolism in sickle cell disease. So bone marrow necrosis refers to necrosis of myeloid tissue and medullary stroma in hematopoietic bone marrow. So the characteristic of bone marrow necrosis is that it causes pancytopenia and leads to the related RBC in peripheral smear. Mostly it is caused by hematological malignancy and rarely by some other autoimmune conditions and sickle disease. So in sickle cell disease, there are no large reviews. This was the largest review published in 2014 by Sisikas and colleagues. They reported 58 patients in the literature that were published from 1941 to 2013. Later, this These colleagues also reported 27 more cases. So total 85 cases they reported till 2019, and he also had some of his 8 or 9 patients on his own clinical experience. So there are not much articles on cerebral fat embolism. This is an article which shows the specific characters of cerebral fat embolism. It compared, it took total 25 patients and 10 of them were cerebral fat embolism. I am summarizing the salient clinical features now. So there is a typical clinical presentation. So the patient presents with a vaso-occlusive crisis of unusual severity. So usually the mild variants, they present with a severe degree of vaso-occlusive crisis, more diffuse pain. That is followed by respiratory failure and then neurological dysfunction and other symptoms. Laboratory data shows low hemoglobin and thrombocytopenia. The thrombocytopenia is a characteristic feature, and there is a markedly elevated LDH and ferritin level. Ferritin levels may be more than 100 times normal. And cardiopulmonary complications like ARDS and shock and fever were more common in patients with cerebral fat embolism. So the bad thing is that these patients have a very poor prognosis. So mortality in up to 2014 was 64%, and thereafter in the next review in 2019 it decreased to 33% cases, probably because of more utilization of exchange transfusion. So transfusion practice greatly affects the mortality rate. This is the important point, because the patients who receive red cell exchange transfusion, their mortality is only 23%, and the patients who do not receive any transfusion, the mortality is around 92%. So the exchange transfusion has a huge impact on the prognosis of this disease. Complete recovery is seen only in 20% around cases. And one thing is interesting that the patients who are traits, they have very poor recovery. They don't recover as homozygous sickle cell disease patients. Coming to treatment, so the red cell exchange transfusion is life-saving, and the goal is to transfuse to HbS and C level of less than 10 to 20%. The idea is that red cell exchange transfusion inhibits the further vaso-occlusive crisis by reducing the sickle RBC percent. The crisis is halted and bone marrow necrosis is halted, and there is no further embolization. The next treatment that these now suggested is therapeutic plasma exchange, because despite red cell exchange, the outcome remains poor. The idea behind plasma exchange is that it can remove the fat droplets and circulating cytokines which are responsible for the inflammatory response syndrome. So most centers perform 5 cycles of plasma exchange. So we have 2 cases with us. Actually, we had 3 cases and I am presenting 2. This is my case. Here a 22-year-old female who is a known case of sickle cell disease for 10 years. She presented with multiple joint pains with crisis for 4 days, followed by altered sensorium after for 1 day. And she had multiple episodes of painful crisis and history of transfusion. On examination, patient was stuporous and there was decerebrate posturing on painful stimuli. There was no petechial rash over the skin. Investigation showed her X-ray chest was normal, and so she did not have any pulmonary involvement and there was no skin involvement. MRI brain showed this picture, that is a star field pattern. So there are punctate DWI hyperintensities involving the basal ganglia, thalamus, and deep white matter and corpus callosum. later we did our MRI hip, which showed geographic areas of altered marrow signal in the acetabulum and proximal part of the femur, suggestive of marrow infarction. On routine test, there was deranged LFT and there was severe anemia. HB was 6.4 gram per deciliter, and hemoglobin electrophoresis was suggestive of HB-SS homozygous pattern. Treatment, we gave 1 cycle of exchange transfusion to her and then 2 units of regular transfusion. As the patient was had very poor Glasgow Coma scale, she was intubated and she was put on mechanical ventilation for a long period. And tracheostomy was also done, and supportive treatment in the form of antiepileptics, hydroxyurea and folic acid were given. The hospital course that patient remained drowsy for around 3 weeks. Then she regained some cognitive functions in the form of recognizing relatives and developed poor speech. When we discharged her after 4 weeks, she could walk with assistance. So this was an example of near complete recovery. The patient was homozygous sickle cell disease. This is second case from Sharma Sir's Institute, Ramkrishna Care. Here a 50-year-old woman without any known comorbidities developed backache for 2 days. She was admitted for evaluation, and where she developed sudden onset breathlessness, and then her sensorium also became altered. She was put on mechanical ventilation due to respiratory distress, but her CT chest was not suggestive of pulmonary fat embolism. There were other findings, but not suggestive of pulmonary embolism. And she had some skin manifestations, and she also had some left subconjunctival hemorrhage. MRI brain revealed changes of subacute fat embolism. Here we can see that there are confluent hyperintensities involving the bilateral basal ganglia, thalamus. So in the subacute stage, these discrete hyperintensities become confluent. MRI spine showed multiple areas of heterogeneous signal intensity in the spine suggestive of infarction. Patient was found to be anemic 8 gram per deciliter, and there was thrombocytopenia. Her hemoglobin electrophoresis was suggestive of sickle cell trait. Patient was managed conservatively with antiepileptics, hydroxyurea and folic acid. This patient had poor prognosis, and she was discharged in bedridden state with residual motor and cognitive impairment. So discussion, both of our patients had cerebral fat embolism, but they did not have pulmonary embolism. So cerebral embolism can occur without evidence of pulmonary embolism. Exchange transfusion improves survival and prognosis, as in our case, in first case, who received exchange transfusion. Although rare, fat embolism syndrome can occur in homozygous sickle cell disease. Sickle cell trait patients have poor prognosis than homozygous patients, like in second case. And sickle cell disease should be suspected in any patient of non-traumatic fat embolism, even in the any absence of any history of prior vaso-occlusive crisis. If this time patient presents with some crisis-like symptoms like pain in the joints, then it should be suspected. So the take-home message is that there is a great need to increase the awareness regarding this syndrome, because the timely diagnosis will avoid delays in treatment, and it can be life-saving. And MRI in preference to CT should be done in case of altered sensorium in sickler patients who present with crisis, because CT is always normal and we can miss it as a metabolic encephalopathy or hypoxic encephalopathy. And immediate red cell exchange is the treatment of choice, and therapeutic plasma exchange could potentially provide additional benefit. Thank you.
Hello. The bone infarct and fat embolism, both are coexist in both same patient?
Yes, sir.
In
It
all
is.
patient.
It
Fat
is.
embolism followed by bone infarct in all patient, or only fat embolism, no bone infarct.
Sir, fat embolism and fat embolism syndrome are two different things. Fat embolism can occur in a large number of patients in serum. Even these patients who are sickler, they have multiple times vaso-occlusive crisis, and if we do sampling for fat emboli in the blood, a large number of patients will show fat globules in the blood. But almost always this doesn't lead to fat embolism syndrome.
Bone infarct in all patient.
Yes, sir, we have evidence of bone infarction in all patients.
All patient, and that's the involvement of spine as well as pelvis.
Yes, sir.
But I think it's dangerous to say this patient has never had a pulmonary embolism. We do not have investigatory support to say pulmonary thromboembolism, but they admitted in a compromised respiratory state and they all required a ventilator. That suggests that there is not a massive or large size pulmonary embolism which is evident on a CT or this thing, but there must be a multiple time.
Sir, but this pulmonary embolism is usually detected on CT. So this is quite.
There is no another pathway for a cerebral embolism. It has to pass through a lung to reach into this.
That is why I described two pathways. One is this mechanical theory, which supports your hypothesis that it has to pass through the lungs. But there is a caveat here. There are patients who present without pulmonary involvement and cerebral involvement. In such cases, they find some or the other right to left shunt in the form of pulmonary AV fistula or a patent foramen valve. And there are cases reported in literature where they have extensively investigated these two things and they have found nothing. I mean, there is no AV fistula and no patent foramen. They have done even transthoracic EEG, echo and extensive pulmonary workup. So, without evidence of pulmonary involvement, it leads to the suggestion that it is in fact an inflammatory response syndrome. That is the second biochemical theory.
Could be, an inflammatory theory is already there. But that time when we picked up this patient, we ourselves are not aware of this syndrome, so
yes,
most of the markers have not been done, like a ferritin, LDH, D-dimer,
we did not
which
do
we
it,
wanted,
yes.
which we wanted to. Fantastic. Pass on all the slides to me because I own a copyright to this.
Thank you, sir.
Could you go back to MRI?
Okay, in that MRI, splenium of corpus callosum is hyperintense,
Yes,
which is a classical boomerang sign which we see in MRI. So it is a rare sight to have this. It is likely in infections or demyelination, and it is a rare sight of infarct. So how will you explain this boomerang sign as a patient of sickle? So
Ma'am, this is a fat embolism syndrome, and it is one of the described sites in fat embolism.
Okay, I was just checking the list.
So
but
this
I
is at this stage, this is actually acute stage.
Okay.
Acute to subacute stage, because there are punctate hyperintensities. They are not confluent at this point. And it is usually seen in the deep white matter, subcortical white matter, and when extensive, it appears in the basal ganglia and thalamus also. And middle cerebellar peduncle, internal capsule, posterior internal capsule, and splenium of corpus callosum. They are the described sites in fat embolism syndrome.
Oh, okay, fine. Thank you.
These are DWI images, so anyway such infarct.
So they present cytotoxic edema, and in SWI images there is walnut kernel pattern. It is also a specific sign because it represents microhemorrhages. So there is a picture.
So Dr. Bhoi, a short case presentation. Make it short. We reward you with another trophy.
So it is also seen diffusely in the white.
नीचे वाला ना स्लाइडर भी देना पड़ेगा इसमें काम कर लेगा ना स्लाइडर में ना डेट से
Thanks, organizing committee, for inviting me for this topic. Since yesterday we are listening about everything, about immunology, autoimmune disorder, everything, affecting brain, spinal cord, everything. So I hope immunology, maybe some few years coming, may some course like DM in neuroimmunology, immunoneurologist may come, and we are nowhere. Maximum bunk of disease will go to the immunoneurologist. And this is a case I have writing is a very rare case I have seen for first time. This is also Dr. seen by or my colleagues Dr. Ritesh also. This is a rare case painted with acute flaccid paralysis in patients of thyrotoxicosis, Graves' disease. Actually, Graves' disease is an autoimmune endocrine disorder affecting thyroid. It is associated with type 1 diabetes mellitus, also other autoimmune disease like Addison's disease, pernicious anemia, and rheumatoid arthritis. It also associated with other neuromuscular disorder like myopathy, exophthalmos oculopathy, periodic paralysis, myasthenia gravis, and very rarely GBS. So, what is the common mechanism between Graves' disease and GBS? We know from their classical study, GBS may be triggered by some viruses, bacteria, and some metabolic disorder like Campylobacter jejuni, Mycoplasma, Epstein virus. And we are hearing in Yersinia group. Yersinia group is usually famous for plaque, Yersinia pestis. But we are not talking. We are talking about Yersinia enterocolitica. It causes Graves' disease by allotype autoimmune triggering mechanism. And in this Yersinia group, in Guillain-Barré is not there. Here is the Mycoplasma, Epstein virus, Campylobacter jejuni is common. The same factor that acts on gangliosides. In thyroid cell, it is called thyrocyte. The cell membrane contains ganglioside. Also in peripheral nerves, and the cell membrane contains gangliosides. So the same common mechanism, both acts on ganglioside, anti-ganglioside. So autoimmune process in both, in theoretically, also in some researches. In Graves' disease, the exact mechanism is not known. This mechanism is proposed. This molecular mechanism, it is published in Neurology India, triggered by some virus, bacteria, in CD4 cell activation, B cell activation, also leads to ganglioside antibody formation. And that is a common mechanism in both GBS and Graves' disease. This is my case, a 40 years old male, known case of hyperthyroidism, in not on proper treatment, developed thyrotoxic symptom, exophthalmos, dyspnea, anxiety, and after 3 to 4 days developed flaccid quadriplegia with bulbar and respiratory fibrillation rapidly. And he had no prior history of hypertension, type 1 diabetes, or rheumatoid arthritis, known case, no history of myasthenia gravis previously. His anti-TP antibody is very high, and we have done technetium thyroid scan, so toxic goiter. Anti-mox antibody, anti-similar antibody are negative. Serum CPK normal, CSF study normal. Viral markers like COVID negative. MRI study normal. CT chest abdomen normal. In nerve study conduction sensitive of GBS, RNS negative. EMG neuropathic. Muscle or nerve biopsy not done in this patient. This patient was treated for thyrotoxic mutation with neomarcazole, propranolol, and also received methylprednisolone. And patient on ventilator support. Patient recovered from thyrotoxic crisis. But there is no improvement in muscle power. So we have given IVIG on 7 days for 5 days. And after 1 week, patient gradually recovers and patient removes ventilator after 1 week. Then significant improvement is muscle gain after 2 weeks. So what literature told till now? Normally in GBS patient prefer plasma exchange or IVIG, vice versa. But in patient, suppose only Graves' disease, no GBS. In Graves' disease, if there is thyroid storm, plasma exchange is advised, even in muscle weakness. Patient needs any surgery, abdominal surgery, chest surgery for any Graves' patient, we should keep down the thyroxine level from hyper to euthyroid urgently, then we should give plasma exchange before any abdominal or chest surgery. Suppose patient is not tolerating propylthiouracil or carbimazepine, having agranulocytosis or jaundice, we have to stop propylthiouracil or carbimazepine. In that case, we have to give plasma exchange so that the patient can be prepared for thyroidectomy or radioiodine therapy. And another, in pregnancy, if there is thyroid storm, in known case of hyperthyroidism patient on pregnancy, sometimes develop thyroid storm due to autoimmune mechanism, or sometimes in gestational hyperthyroidism. In this case, plasma exchange is given, there is good recovery. So, patient with Graves' disease, with GBS, there is also some series of plasma exchange therapy in GBS, but there is no yet some randomized control trial. So, what is the role of IVIG? Second, if patient with Graves' disease developed ophthalmopathy, we can give the treatment modalities, first antithyroid drug, propylthiouracil carbimazole, or radioiodine therapy. If patient not improved in ophthalmopathy, we can add steroid. If not, we can give IVIG. Other modalities, orbital radiotherapy also tried. If resistance cases of orbital ophthalmopathy in Graves' disease, we can use mecaplenolate, methotrexate. In severe cases, we can use monoclonal antibody, rituximab or tacrolimus also. So, if the patient Graves' disease associated with GBS, we can choose plasma exchange or IVIG, or vice versa. But most of the literature I will reviewed, plasma exchange, most of the endocrinologists giving plasma exchange for treating ophthalmopathy, and most of the neurologists giving IVIG for treating GBS part. So, in my conclusion, GBS associated with Graves' disease, it is a very rare case. Autoimmunity play a possible role, and more trials are needed to comment on therapy when both Graves' disease and GBS coexist. So, we are talking about GBS in hyperthyroidism. Whether it can occur in hypothyroid patient, Guillain-Barré syndrome is very rare because of autoimmunity. It develops in Graves' disease, thyrotoxic patient. Whether it can occur in hypothyroid patient, the answer is yes, because autoimmunity plays a role in Hashimoto thyroiditis. It is also called chronic lymphocytic thyroiditis or autoimmune thyroiditis or Hashimoto's. There are various names, but it is chronic lymphocytic autoimmune thyroiditis. So the mechanism is same in Graves' disease, also in Hashimoto thyroiditis. Here usually we diagnose simply by T3, T4, TSH report is usually normal, but there is presence of antibody, very high titer of anti-TP antibody. In this case also, it is associated with Guillain-Barré syndrome. It is also very rare. Another case is Hashimoto thyroiditis, multifocal motor neuropathy. In Graves' disease, multifocal motor neuropathy is in many cases present. Even if there is no other clinical manifestation, in electrophysical studies show multifocal neuropathy in asymptomatic neurologically Graves' disease patient. So in this case also the pathology is same autoimmune. We can choose either plasma exchange or IVIG. So it is very rare case. And treatment modality is plasma exchange or IVIG. But the literature in search, there is no so much large series, there is no recommended, no RCT trial. But plasma exchange is preferring by ophthalmologist and rheumatologist for ophthalmopathy features treatment, and we are neurologists choosing IVIG mostly for treating muscle weakness, GBS type. Any question?
Whether it's done, Dr. Bhui? So we invite any question on this particular topic. It's not very clear to me what's the status of a TPO antibody or whether Hashimoto's encephalitis exists or not exists, because there is a lot of controversy here.
There is associated. The exact mechanism is not yet proven. The suggestion is anti-ganglioside antibody present in cell membrane of both thyroid cell and neuron. That is one of the proposed mechanism. And patient improved with both plasma exchange and IVIG. So indicates there is autoimmune role in both cases. And both patients are improving with plasma exchange and IVIG. There are many single cases or small cases of series.
What's the status of a TPO antibody is in a hyper and a hypo group? Whether you have done a TPO in this patient?
In this Graves' disease, anti-TPO antibody is very high.
You have done in your case?
Very high.
This was very high. Thank you. You have got a question.
We have a DM endocrinologist with our team there in MGM. So he said that at normal population, the incidence of anti-TPO antibody positivity is around 26 to 30%. Asymptomatic patients, an asymptomatic person can be anti-TPO positive with normal euthyroid status, 26 to 30% patients. Moreover, considering the seasonal as the conjunctivitis and seasonal viral variants are there, COVID variants, so number of GBS we all have seen have increased in last few months. So how will you attribute it only to that anti-TPO positive hypothyroid is per se linked with the GBS? Or why not it is just a seasonal GBS?
Seasonal GBS.
Yeah,
because this patient was treated with, by endocrinologist with treatment for Graves' disease with neomarcazole, propranolol, everything given solumeter for 5 days. There is only improvement in thyrotoxic patient. The thyrotoxic Graves' part is improved, but the paralysis did not improve. Patient was in ventilator for 7 days. Then we have given IVIG searching literature, then IVIG or plasmax is very special. It is during COVID time. So I have given IVIG and patient improved.
So anyhow, GBS will improve if it is viral or it is
GBS will
thyroid.
improve with IVIG plasmax, but it is associated with Graves' disease, and patient was not improving with the only treatment of thyrotoxicosis part.
Yes, it was controversial.
It's a bit controversial, it's more than a controversial. So what happened, they are the two entities which are not considered to be a very specific. One gone is a PANDA, which was a post-streptococcal neuropsychiatric behavior that was called as a PANDA. So they said those antibodies are not specific, we should no longer make a diagnosis of PANDA. Another one which gone into a problem is a Hashimoto's encephalitis. Hashimoto's encephalitis is gone, but endocrinologists always retain a diagnosis of Hashimoto's thyroiditis. So this is something which is quite different. The endocrinologists accept the term of diagnosis of Hashimoto's thyroiditis, and they said that Hashimoto's encephalitis is not specific because TPO antibody is positive in a many of normal patients, and in most of the euthyroid patients. Most of the patients are euthyroid. So this is the current status. Yeah, there is one more.
Good afternoon, sir. But this is not case of antibody negative myasthenia gravis.
What is?
Antibody negative myasthenia gravis.
Maybe. But a patient have a clinical exophthalmos, dyspnea, tremor, everything, features of Graves' disease, clinically.
No, antibody negative myasthenia gravis. This scenario, sir, case scenario.
It is clinically not. Patients have features of Graves' disease.
IVIG on improve na IVIG or motor adrenal neuropathy, placid paralysis.
Initially received solumetrol 5 days, not improved, patient was on ventilator.
CSF is normal.
CSF normal.
And sensory involvement normal NCV में.
Repeated nerve stimulation not suggestive. I have tried. Neostigmate also tried. RNS also negative. No ocular pressure. Exophthalmos, classical.
Yes. Okay. Yes.
Eh?
What was the follow-up?
Yeah, follow-up. If he is doing well without any cholinergic drugs, because maybe if IVIG is given how many months back or so?
नहीं सर जीबीएस के सपोर्ट में सीएसएफ स्टडी नहीं है, सेंसरी इन्वॉल्वमेंट नहीं है एनसीवी में, तो कैसे रूल आउट कर सकते हैं प्लेसेंट पैरालिसिस में जीबीएस वर्सेस माइस्थेनिया को?
Exophthalmos, toxic goiter. In technisms, there is toxic goiter also. Technism, we have done toxic. Technisms can toxic goiter.
No, this GBS like presentation, Dr. Bhoi, is how many days or months back till this date? It was 2 months, 3 months, 4 months?
This patient was? During COVID time, first 2 years back.
So what is the follow-up of that patient?
Patient came 1 month after this. Patient on only neocarbamazole, patient doing well.
So now also we should think that patient
not coming after this last 1.5 years.
Follow-up only you have?
Only single follow-up.
So as far as the earlier description of this hyperthyroidism, Graves' disease associated with the hypokalemic disorder or this kind of disorder is described in a Chinese. So if you go into a Chinese literature, you are going to know the cause of it. So that's it, Dr. Bhoi. Thank you. We move on to a last presentation. Ditesh. So this is already published by Ritesh, laryngeal carcinoma, presenting as polymyositis in a very high rating journal.
Yes.
So start with it.
Good afternoon, sir. First of all, I would like to thank Dr. Sanjay Sarma, sir, for keep on motivating to deliver a talk in this wonderful conference and stick to the chair till the end of this conference. So I am the last one to present over here. It's not moving. You know. Excuse me, slide is not moving here. So, just a minute. एक मिनट इधर आइए तो ये मूव नहीं हो रही यहाँ पे यहाँ से अच्छा और यहाँ से यहाँ कहाँ हो रही और यहाँ कहाँ मूव हो रहा है हाँ ये वाला अभी मूव कर हाँ okay. So today I am going to present a case of rare case of laryngeal carcinoma, which was presented as a polymyositis. It was a paraneoplastic neurological event. So coming to the history, a 54-year-old male who was presented with progressive weakness of both upper and lower limbs with associated myalgia, body pain for last 2 months. He had difficulty in climbing upstairs, getting up from the chair. He also had difficulty in combing hairs and lifting arms above the head. This weakness rapidly progressed over the period of 2 months and he became bedbound. There was no sensory complaints. There was no fever, rash, joint pain or any other systemic complaints like cough, dyspnea. There was no any contributory drug history relevant to this presenting complaint. However, he has given a history of hoarseness of voice for last 2 weeks. On examination, his vitals were stable. There was no skin lesion, low lymph node enlargement. Higher mental function and cranial nerve examinations were normal. On motor examination, there were hypertonia in all 4 limbs. Power grade was 3/5 in all 4 limbs, predominantly involving the proximal muscle groups. Distally, the power was normal. Deep tendon reflexes and sensory examinations were normal. So to summarize, a 54-year-old male presented with subacute onset of progressive pure motor quadriparesis involving symmetrical proximal muscle group without bladder wall involvement with intact higher mental function and cranial nerve examination. So with this summary, our localization of lesion is in the muscle, less likely in the roots because there is a sparing of distal muscles because distal muscles power was normal. So we did the investigation, all routine blood investigations were normal. Thyroid, parathyroid and vitamin D level were within normal limits. We did the autoimmune profile like ANA, ENA and myositis specific autoantibodies assessment. They were negative, but the total CPK level was quite high, it was around 9,000. So the clue is toward the myopathy. We did the EMG, it was suggestive of myopathic patterns like short duration, low amplitude, polyphagic potentials. We have subjected the patient for muscle biopsy, it was taken from right quadriceps and it shows infiltration of chronic mononuclear cells, and this is the slide. You can see these mononuclear cell infiltration involving the perimysial and endomysial area with slight muscle damage and myophagocytosis. This biopsy picture is very typical of polymyositis. In case of dermatomyositis, usually we get perifascicular atrophy. So this is not here. In view of hoarseness of voice, we did the direct laryngoscopy and it was revealed laryngeal growth. Biopsy done from the laryngeal mass and it was suggestive of squamous cell carcinoma. Other investigations like chest X-ray, CT abdomen and serum prostate specific antigens were within normal limit. So case discussed with oncosurgeon, and the oncosurgeon has treated this with total laryngectomy followed by radiotherapy. Patient was also started on prednisolone with a dose of 1 mg per kg per day and azathioprine 2 mg per kg per day. Periodic power charting was done over the period of time, and on follow-up he had regained almost all the muscle strength with complete normalization of CPK level. So slowly prednisolone was tapered off and patient was continued with the same dose of azathioprine. So coming to the inflammatory myopathy, polymyositis and dermatomyositis are the inflammatory myopathies of unknown origin. Dermatomyositis are characteristically associated with some skin lesions like Gautran papules over the extensor aspects of the hand, heliotrope press involving the periorbital areas, and facial erythema. And polymyositis lack these skin features. It has been found in all studies dermatomyositis are more commonly associated with malignancy as compared to polymyositis. And the commonly associated malignancy with these inflammatory myopathies are the CA cervix, ovary, pancreas, bladder, and stomach. This is the first case of laryngeal carcinoma which was presented with myositis. Till date, we have reported this case. So the pathophysiology behind this paraneoplastic event is there is an expression of common autoantigens between the cancer tissue and muscle tissue in some patients with inflammatory myopathy, and because of these molecular mimicry, immune response which was directed at the tumor cells, it also targets the similar autoantigens in the muscle tissue, which results in the myositis or muscle damage. So as per the definition of paraneoplastic neurological syndrome, it can affect any part of nervous system, and it often presents as a stereotype clinical manifestations. It occurs in association with cancer, and it has some immune mediated pathogenesis that is already supported with presence of few specific neuronal antibodies. So these are a few myositis specific autoantibodies which are commercially available and routinely done by a few labs. Among these, the above two antibodies like anti-TIF1 gamma and anti-NXP2, these autoantibodies are also known as high risk antibodies because they are commonly associated with malignancy. Rest of the antibodies are also found in patients with inflammatory myopathy, but they are low risk antibodies. There is a low risk of malignancy in these patients. The third one is anti-synthetase antibody. It is the positivity of this antibody suggests another entity of inflammatory myopathy which is known as anti-synthetase syndrome, and there is a very low risk association of these anti-synthetase syndrome with malignancy, and there is always an association with interstitial lung disease. So other risk factor for malignancy in a patients with inflammatory myopathies are the age of presentation or disease onset is old age. There is a severe cutaneous manifestation as we have discussed with dermatomyositis. If any inflammatory myopathy which is not responding to routine immunological treatment, then you should always look for the malignancy or any occult malignancy, because paraneoplastic cause may be there. That's why these inflammatory myopathy is not responding to routine immune mediated therapy. If there are any prior history of malignancy, then there could be a relapse of that malignancy and presence of these high risk antibodies. So the learning point from this case is, as this is the first case of laryngeal carcinoma which was present as a polymyositis. It was a paraneoplastic event, and in this case laryngeal cancer was detected within 3 months of onset of paraneoplastic event, and patient was recovered with anti-cancer therapy along with immunosuppressive therapy, which suggests the possible paraneoplastic association. The diagnosis and management of underlying cancer along with immunotherapy in the early possible stage of neurological event in a patient with suspected paraneoplastic syndrome may hasten the recovery of that neurological event. And lastly, the treating physician should be aware of doing direct laryngoscopy as a part of routine cancer screening test whenever you encounter such patients of suspected paraneoplastic neurological manifestations. So finally, this case was published in Annals of Indian Academy of Neurology. Thank you.
Is there any evidence of metastasis in this case, laryngeal carcinoma? Metastasis?
No, sir, no.
PET scan?
No, we have not done the PET scan, sir. It was in the institute. We did the routine X-ray chest, USG abdomen. We did serum PSA level. They was all negative.
I think this case is done in the era when the myositis specific antibody was not available.
Yes,
and
yes,
PET,
2016.
PET scan was not that easily
We are not doing
available. So
regularly
these
that
two
time.
things are not done, but case is amply clear, it's more than clear, and it gives us a great learning. So nowadays it's mandatory to get PET scan possibly in all patients of polymyositis.
Yes, yes, but sir, we cannot shift every patient for PET scan. So as a basic screening test, when we are doing a chest X-ray, USG abdomen, other blood investigation, then we can do a laryngoscopy as well, because it's just a OPD procedure. The ENT surgeon can do it regularly. When an asymptomatic patient of laryngeal carcinoma, there are few patients. Most of the laryngeal carcinoma are usually supraglottic, so they are asymptomatic till late stage of disease.
So there is no change in a voice or something, or speech is.
Sorry, there was hospice of voice since 2 weeks. But in asymptomatic cases, I recommend to do laryngoscopy as a part of routine screening. That's the reason for this.
Your point is well taken.
Thank you, sir. Thank you. Any questions?
So I think after the 2 hectic days, we are reaching to the end of this marathon. And I'm sorry about our audience, number of audience, and the many of them gone down because of this new regulation which propped up the comparative judgment. But the scientific contents of this conference was very, very good, and all the orators are superb. So is the audience. Thank you.